Hi, everyone. Welcome to Plenary Session 4. What can we tell our patients? I'm really excited to introduce to you a whole panel of guests who are experts in this field, and I really look forward to the discussion that will follow these initial presentations. First up, we have Melissa Hudson from St. Jude's Children's Research Hospital, where she is a member and director of the Cancer Survivorship Division in the Department of Oncology and holds the Charles E. Williams Endowed Chair of Oncology Cancer Survivorship. She directs the St. Jude After Completion Therapy Program, which now monitors over 8,000 long-term childhood cancer survivors treated in St. Jude's trials. Dr. Hudson disseminated the St. Jude model of risk-based survivor care. And so she's truly an expert, and I look forward to her comments.
Good morning. To provide some essential background to kick off this session, I will briefly address factors to consider when implementing health promotion across the cancer care continuum. Within this session, panel members will discuss what we can tell our patients about 3 lifestyle issues featured in AICR recommendations to prevent cancer: weight control, diet, and physical activity. Notably, the recommendations provide a caveat for individuals diagnosed with cancer. Follow our recommendations if you can. I would like to briefly provide some context for that stipulation that considers the challenges of engaging cancer patients and survivors in health promotion initiatives. Health promotion across the cancer care trajectory involves care of individuals who will receive treatment with curative intent, many of whom will achieve cancer-free survival, as well as individuals who may live for extended period of time on palliative treatment. This care trajectory is accompanied by survivorship trajectories that include individuals living cancer-free for the remainder of life or experiencing serious late complications of treatment or a late recurrence or developing a second cancer. Individuals living with cancer may have intermittent periods of active disease requiring treatment or live continuously with cancer. There are challenges to implementing health promotion initiatives across the cancer care continuum that are important to consider. Physical challenges include chronic comorbidities, treatment toxicities, chronic symptoms, all of which may impair functional status. Psychological challenges include the impact of cancer on aspects of emotional health, cognition, and perceived quality of life. And social challenges may involve economic, educational, and environmental factors, access to community support, and access to resources. So these challenges may limit an individual's ability to prioritize or focus and participate in health promotion activities during cancer care and after completion of therapy. In subsequent slides, I'll present research findings related to several of these factors to highlight the relevance and potential impact on health promotion. The presence of comorbidity affects the care of cancer patients, many of whom are living with multiple comorbidities. So this slide features results of a UK study that linked cancer registry records of patients diagnosed with 4 types of cancer: colon, rectum, lung, and Hodgkin lymphoma, with hospital admission records. The study targeted 14 comorbidities, which they defined by a hospital admission up to 6 years prior to cancer diagnosis and available in the hospital records. Up to 2/3 of patients within each of the 4 cancer patient cohorts had at least one comorbidity, and around 1/2 had multiple morbidity. And multimorbidity was consistently higher in economically deprived cancer patients. You can see the most common comorbidities included hypertension, COPD, and diabetes. Now, multimorbidity is also common in adults treated for cancer during childhood. This figure illustrates the cumulative burden of multimorbidity across organ systems in participants in the St. Jude Lifetime Cohort Study. The cumulative burden is a metric that considers recurrent and multiple events within the context of competing risk. The proportion of organ-specific conditions, noted in color codes here, is illustrated by the specific cancer diagnosis at age 30, 40, and 50 years. and the cumulative burden of community controls is noted on the far left. And one can see that the burden of some conditions increase over time, such as the case with cardiac disease and Hodgkin lymphoma survivors, while other conditions remain static over time, such as neurologic toxicity and central nervous system tumor survivors. So the prevalence and type of multimorbidity in survivors of both adult onset and childhood onset cancer emphasize the importance of considering how physical factors may influence adherence to health promotion efforts. Adults with non-central nervous system cancer frequently report problems in attention, memory, and executive function during or after chemotherapy. And this study involved a meta-analysis of functional MRI studies to evaluate regions of hyper and hypoactivation in chemotherapy-exposed patients. Brain areas identified showed consistent functional changes in cognitive tasks. Hypoactivity was associated with functional abnormalities in attention and executive function. So you can see lower activations in the brain, noted in blue, were hypothesized to reflect depletion of cognitive reserves that could explain mental fatigue and pose a barrier to participation in health promotion activities. Chronic symptoms experienced by cancer patients during therapy and by long-term survivors many years after treatment may adversely affect aspects of physical and psychosocial functioning. So this slide features results from another St. Jude Lifetime Cohort study that evaluated the impact of pain on daily functioning through clinical assessments of medical, cognitive, and physical performance, and associated these with patient-reported pain, health-related quality of life, and social functioning. Approximately 18% of survivors reported moderate to very severe pain that was associated with moderate to extreme daily interference, and pain with daily interference was associated with risk of impaired neurocognition, as noted in the figure, impaired physical functioning, and impaired social functioning. Some cancer patients and long-term survivors suffer from psychological problems, such as depression, that may interfere with coping with illness and treatment burden and adherence to health promotion. So this meta-analysis of diagnostic interviews and self-report instruments pooled data from 211 studies to evaluate the prevalence of depression in adult onset cancer patients. The pool mean prevalence for depression ranged from 8 to 24%, with prevalence differing by the type of assessment, whether it was a diagnostic interview or obtained through a self-report, and also the cancer treatment phase, acute, less than a year beyond treatment, or more than a year. And so overall, these results highlight the importance of addressing mental health in the context of health promotion. And finally, health behaviors are likely influenced by social factors such as neighborhood of residence that can affect access to healthy, affordable food and safe and easy exercise options. So this figure illustrates a geographic distribution of childhood cancer survivors by obesity status in the St. Jude Lifetime Cohort. Survivors with high body fat are indicated in blue, while those with normal body fat are indicated in yellow. And obese survivors, who comprised almost 63% of the cohort, were more likely to live in neighborhoods with a lower socioeconomic status and in rural areas compared to those with normal percent body fat. Living in a resource-poor neighborhood was associated with increases in percent body fat, even after accounting for known health behaviors, demographic, and treatment exposures associated with obesity in this population. Associations between neighborhood of residence and percent body fat were also increased among individuals with a poor diet. So these data provide useful information that should be considered in clinical and research programs promoting health weight maintenance and weight reduction during and after completion of therapy. So in summary, I hope I've convinced you with these few examples that the experience, needs, and perspectives of cancer patients vary substantially and change over the cancer care continuum. Considerations of physical, psychological, and social factors is critical to engage cancer patients in health promotion efforts. And so I'll now turn the virtual podium over to my colleagues who can share the practicalities of health promotion initiatives related to diet, weight control, and physical activity.
Next, I'd like to welcome Wendy Demark-Wahnefried, who is a professor and Webb Endowed Chair of Nutrition Sciences at the University of Alabama at Birmingham. And she's also the Associate Director for Cancer Prevention and Control at the O'Neill Comprehensive Center, also at the University of Alabama. Her research ranges from determining mechanisms of action of nutrition-based therapies to developing and testing home-based interventions that are scalable and which improve diet, physical activity, and functional status among cancer survivors. Dr. Demark-Wahnefried has been recognized as a Komen Professor of Survivorship and an American Cancer Society Clinical Research Professor.
Hi, I'm Wendy Demark, and it's a real pleasure to be here to talk about what we know and what we don't know about diet after a cancer diagnosis. So I'm going to be talking about the known, which is the much smaller circle that's featured there in yellow, the known unknown, which is a larger circle in blue, and then also tapping into the unknown unknown, which is even larger. So the strategies for assembling this talk, in talking about the known, I'm relying on systematic reviews, pooled and meta-analyses, and multiple RCTs. The known unknown, single and observational studies, and the unknown unknown, you're on your own. So survivorship, the known. Dr. Hudson already talked about this. Cancer survivors face the possibility of recurrence. That could be anywhere from less than 10% for thyroid cancer and receptor positive breast cancer to about 100% in glioblastoma. Their odds of having second cancers is around 34%, and cardiovascular disease much higher. So the known unknown data are still accumulating with regard to how diet and exercise impact the risk of recurrence. However, we do know that cancer survivors have roughly a 34% increased risk of a second cancer, a 300 to 400% increased risk for a poor CVD profile, 66% increased risk of stroke, and 80% increased risk of dying from cardiovascular disease. And we do know definitively that diet and exercise are key for managing these conditions. So here are the cancer-related diet recommendations of the WCRF and AICR, ACS that we typically counsel our patients on. And at the very top of both of them are the importance of weight management. Be a healthy weight or achieve and maintain a healthy weight throughout adulthood. The AICR points out that there's limited suggested evidence with regard to having an increased risk for body fatness post-diagnosis. The known, obesity is a risk factor for several cancers, 13 to be exact. And we also know, given pooled analyses that occurred after these reports from 20 prospective cohorts in over 1 million women, that weight gain after age 20 is significantly associated with breast cancer risk for hormone-positive disease. And that might actually be increased in women who start off as lean, who have BMIs less than 20, but who gain substantial weight during adulthood. And the known, obesity is also a poor prognostic factor for 15 different cancers. Here are the point estimates and the confidence intervals for male and female cancers. Note that some of the cancers that are talked about in this conference, such as metastatic melanoma, are not on this list and may be different cases. Also known, weight gain adversely affects cancer-related outcomes for 2 prevalent cancers. Here we draw upon the meta-analyses for breast and prostate cancer. For breast cancer, a meta-analysis by Chan showed that breast cancer-specific mortality was increased by around 30%, and total mortality by 8%. For every unit of weight gain that was demonstrated in breast cancer survivors. And for prostate cancer survivors, we know that biochemical recurrence and prostate cancer specifically is basically increased by 20% in men that gain a comparable amount of weight. We also know that purposeful weight loss improves survival in the general population. And here is the meta-analysis results of MAW, drawing upon 54 RCTs of over 30,000 adults with obesity, and found that the risk ratio for all-cause mortality was decreased by about 20%. However, unknown, will purposeful weight loss improve cancer-related outcomes and survival in populations with cancer? That we don't know right now. However, the known unknown is that we have two large RCTs which will yield survival outcomes soon. The first is the LIVE study by Cindy Thompson, and that is an ovarian cancer, not a structured weight loss program per se, but one that is a lifestyle intervention that promotes a low-fat, high-fiber, high-fruit and vegetable diet with increased exercise, which is likely to yield weight loss among ovarian cancer patients. The second one is the Be Well trial, and that is among over 3,000 women in the United States and Canada, which really is a structured weight loss program based on the Look Ahead trial with telephone counseling of the LISA trial. That's an event-driven analysis, and the results are expected in roughly 2024. So be on the lookout for those trials. However, we do know that among the trials that have been done in survivor populations and from the Cochrane analysis of SHAKE that was reported last year, that in breast cancer patients, there's no increase in adverse events, that these weight loss trials do result in decreased adiposity, that when you combine diet and physical activity together in a multimodal intervention, you get more weight loss. There's really, the effects on quality of life are very heterogeneous, so we really don't know what those impacts are. And we don't see any results as far as decreasing anxiety or depression. But we do see that triglycerides and leptin are decreased in these populations that lose weight, which are all good, but no differences in other biomarkers. Among the meta-analyses that have been done in endometrial cancer, we find, again, no increase in serious adverse events. So these weight loss interventions appear safe. They result in decreased weight. Their impact on quality of life is unclear. And for endometrial cancer survivors, these might actually result in perhaps more musculoskeletal events. So also what we know, the guidelines for overweight and obesity, which have been basically set every couple of decades, and the most recent one was in 2013, is that weight loss of 2 pounds per week in adults is safe, to go slower in younger as well as older populations. Since the mean age for a cancer diagnosis is 66 years, these are older adults, and therefore we should be taking it a little bit slower in these individuals. An energy restriction of around 1,200 to 1,800 calories per day, with increased physical activity and behavior modification as represented at the base of that pyramid there. There's no recommended percentages with regard to distribution of carbohydrate, fat, and protein. All work equally as well. However, there are some tools that are very effective, such as self-monitoring, weighing every day, as well as keeping a food journal. In fact, Hedges, in a review of various strategies, basically looked at the strategies that are used among cancer survivors and find these same strategies effective: goal setting, self-monitoring, goal setting with regard to weight, as well as the food behavior, as well as the other things that you see here, biofeedback, etc. So other cancer-related diet recommendations. Let's talk about the dietary pattern. Here, eat whole grains, vegetables, fruits, and beans, and the WCRF suggests there's limited suggestive protections for foods high in fiber, as in survivors that are at least 12 months past diagnosis. Also, limit red meats, sugary drinks, and fast foods. So what do we know? On October 26, 2015, IARC, or the World Health Organization, proclaimed that red meat was a carcinogen. Here, the evidence was fairly strong, with processed meats being given a Group 1 classification as known carcinogens, and red meats Group 2A classification, which is a probability. There have been other analyses after this with pooled relative risk for adding 1 daily serving, again reinforcing these WHO or IARC recommendations of limiting red meats. And then also there was a little bit of controversy about a couple of years ago from the groups there below, which was really kind of blown up in the news. However, even though the interpretation of these findings suggested that there was low or very low certainty regarding the evidence regarding these criteria, the relative risk reductions for a 3-serving decrease per week were still protective. So again, red meat is one of those things, red meat and processed meat are one of those things that we do tend to limit in among cancer survivor populations. But the known unknown, will eating more fruits and vegetables reduce cancer outcomes? Here we have results of 2 carefully conducted randomized controlled trials that looked at high vegetable plus or minus fruit diets. The WELL study promoted over 5 servings of vegetables per day, 16 ounces of vegetable juice, 3 fruit servings, and also combined that with a low-fat diet. The meal study, over 7 vegetable servings per day. It was a little bit of a surprise, but neither one of these trials resulted in reduced cancer outcomes. However, the caveats are that the WELL trial started off with women who were already consuming a high fruit and vegetable intake, and that the meal trial may have been underpowered. So what is the known as far as how we counsel our cancer survivors? We do know that dietary components are important for overall prevention. Fruit and vegetable consumption is inversely associated with obesity, cardiovascular disease, and overall mortality. Whole grain consumption is inversely associated with obesity and cardiovascular disease. And we also know that sugar-sweetened beverages are strongly associated with obesity, type 2 diabetes, and cardiovascular disease. So although we may not have clear evidence that making these recommendations is important for cancer outcomes, we do know it's important for overall health, and that we do recommend 4.5 to 5 cups of fruits and vegetables per day. That as far as grain consumption goes, over half of the grains consumed should be whole grains, and that sugar consumption should be less than 10% of total calories, or 5 to 10 teaspoons a day, less than 6 teaspoons for women and less than 9 teaspoons in men. We also know that high diet quality is very important in relation to disease incidence and mortality. This we know from a very nice meta-analysis of 113 studies over 3 million people by Morse that was reported last year, that showed that overall mortality, as well as cancer-specific and overall mortality in cancer survivors, was reduced when overall diet quality was high, as shown there in the blue bars. We also know that the incidence of type 2 diabetes and neurodegenerative diseases is decreased with high diet quality, as featured in the yellow bars. And we also know that both incidence and mortality are decreased for cardiovascular disease and cancer with high diet quality. So that really begs the question of meal patterns and prudent versus Western diets. And over the years, there have been studies done in breast cancer survivors as well as GI cancers. And the upshot of these is really on the bottom row here, a meta-analysis by Schwedhelm that looked at prudent, which is a diet that's high in whole grains, fruits and vegetables, versus the Western, which is a diet that you can pick up at your local fast food restaurant, and found that with a prudent diet, the risk of all-cause mortality is reduced by roughly 23%, whereas if you eat a Western diet, it is increased by a factor of about 50%. We also know that alcohol and cancer, the association is linear. No amount is really safe for the cancers that are featured there on the left-hand side. Alcohol damages cells, it affects hormones related to breast cancer, and it breaks down into cancer-causing carcinogens. What we always balanced this with was evidence with regard to reducing cardiovascular disease. But more recent studies show that the protection that's afforded from cardiovascular disease is not as great as we once thought, and really only relates to light drinking of 7 drinks per week, which is much different than we had previously thought. And we always gave men the benefit of the doubt, and they could have up to 2 drinks a day. And clearly that puts them at risk. So our advice with regard to alcohol consumption is to limit as much as possible. So in wrapping this up, adherence to the totality of the WCRF AICR dietary guidelines is associated with a lower cancer risk overall. And here is a nice meta-analysis that was done by Jankovic a few years back that showed that there was reduced risk with a diet score that was based on energy-dense foods, plant foods, red and processed meats, and alcohol beverages. And for those individuals who followed the guidelines, they had much lower cancer risk. Finally, we know that there's a need for lifestyle interventions in cancer survivors. And here are the results of a meta-analysis that was recently done on 51 studies, and showed that cancer survivors, a majority of them are overweight. They eat low-fiber diets that are low in fruits and vegetables. They eat high-fat diets, and over half eat over 18 ounces of meat a week. 57% are underactive, and there are a substantial proportion currently smoke and have intakes that exceed the recommendations for alcohol. So 77% practice bad multiple behaviors, and this is an area that all of us can be more active in. So I'd encourage all of you to do so. And last but not least, to say that UAB is recruiting faculty in obesity, metabolism, nutrition, as well as pre and postdocs in this area. So come and see us.
Next up is Kathryn Schmitz from Penn State Cancer Institute, where she is a distinguished professor in the Department of Public Health Sciences and the Director of Oncology, Nutrition, and Exercise, or the ONE group at the Penn State Cancer Institute. Dr. Schmitz's research focuses on people living with and beyond cancer and investigates the role of exercise in improving physiological and psychosocial outcomes, including symptoms, treatment, tolerance, and other chronic diseases. Her research on resistance exercise and breast cancer-related lymphedema has been translated into physical therapy delivered program called Strength After Breast Cancer that is available in over 800 locations across the United States and beyond. She founded the Moving Through Cancer initiative of the American College of Sports Medicine, which is a bold goal of making exercise standard of care in oncology by 2029.
Thank you so much for that kind introduction. Thank you to the meeting organizers. This has been a fantastic conference so far. Looking forward to the rest of it. And I'm looking forward to sharing with you about how to implement exercise during cancer treatment, barriers, and facilitators. So I believe the first thing that I'm going to share with you is my disclosures. And then what I'll jump right into is that if you were to do a search in PubMed today and use the terms exercise and cancer and process with human beings, you will get over 15,000 entries. And so it shouldn't be a great surprise that there have been a number of guidelines that have proliferated around the world, from Australia, 2 sets from Australia, several different sets of guidelines from the United States and other major Western nations, including the ACSM guidelines that I had the good fortune to be connected to that were published in 2019. The results of this and guidance for what patients should be doing are very broadly available and probably very familiar to this audience. What, however, is also known, likely to most of this audience, is that the current state of implementation is that exercise oncology is not standard of care. The minority of patients are adequately physically active. There are a number of causes for this lack of implementation. There's a lack of awareness of the value and safety of exercise on the part of cancer patients and their providers, and a lack of awareness of programming on the part of both patients and providers. There's also an issue with lack of programming in a variety of places. There might be many programs in large cities like New York or Philadelphia, but there may not be very many programs available to cancer patients that are being seen in the community in more rural settings. There's also documentation in peer-reviewed literature of a low rate of referral to exercise programming by clinicians. And there is an enormous issue of a lack of an exercise oncology workforce that I'm going to talk to you a little bit about today. And finally, there is the issue of payment for this programming. Who is going to pay for it? And that becomes a health equity issue. If we say that the patient is going to pay for it, then lower income, minority, and rural patients will have a more difficult time accessing this useful intervention. There are a number of themes towards the goal of broad implementation of exercise oncology. And as president of the American College of Sports Medicine, my presidential initiative was to start the Moving to Cancer program, which lives under the umbrella of the Exercise as Medicine initiative from ACSM. It was the first disease-specific initiative under Exercise as Medicine. A team of experts came together as a task force in 2019 to ask the question, if we wanted exercise to be standard of care by 2029, what would need to happen? And the answer was that there were 5 themes, and I'm going to walk through some of these. I don't actually have time in the confines of my talk today to go through all of them, but we'll talk through some of these today. The first is policy. Policy is kind of a big dog in this question of implementation. And there are multiple layers and levels of thinking about policy here. And at the level of federal government or third-party payers or private payer as well, we first will just notice that exercise oncology interventions will require funding. It does require funding to carry out these programs. And there are a variety of options for how to do that. One is to have them all delivered by healthcare professionals. So if physical therapists deliver all of exercise oncology, then we're covered. We already have coverage by third-party payers. There are reasons why that may not be the best choice. We can also change policy so that exercise professionals who are trained specifically in working with oncology patients become healthcare professionals, become licensed healthcare professionals. There are pitfalls in that direction as well. And the third option that we are exploring Moving to Cancer is to demonstrate that exercise oncology programs are effective in community settings so that we can change policy, not to cover the professionals, but to cover the programs themselves. This is the diabetes prevention program model. There are issues in determining how best to proceed in all of these options, including the fact that we have a big problem with workforce preparedness, which I'll talk about more in another slide. But regardless of the choice that we make about which direction we would go to try to address the issue of funding at the federal level, there is an ongoing issue, even in the programs, the exemplar programs that we can look at to see how might we do this with referrals. The DPP does not get high referrals. Cardiac rehabilitation does not get very good referrals. Exercise programming for PAD does not get great referrals. Cancer rehabilitation delivered by physical therapists does not get very good referrals. So the referral issue will remain an issue even after we obtain funding for those programs. There's also policy issues at the level of organizations. The American College of Surgeons Commission on Cancer puts out standards, and those standards guide how cancer centers behave. Their little sister, the National Accreditation Program for Breast Centers, does the same, specifically for breast centers. And the example that I will give of how this drives behavior is that there was a time when Jimmy Holland from the Memorial Sloan Kettering went on a campaign to try to make us all much more aware of the value of measuring, screening for psychosocial distress, and then referring people to care for that psychosocial distress if they needed it. And the ACOS COC adopted that as a standard. And so all centers across the country that were accredited by the COC had to adopt that standard. What would happen if we had a standard that said that all cancer centers needed to assess, advise, and refer patients to exercise oncology programming? That is something that is being worked on even as we speak. In addition, even at my own home organization, there are organizational issues to be dealt with. For example, there is this thing at ACSM called the Guidelines for Exercise Testing and Prescription. On our 11th edition, it is the Bible across the world for exercise professionals, from YMCAs to clinical hospital-based testing centers, physical therapists, nurses, anybody who's doing any exercise testing will use this as their guide for what is safe and what should be done clinically to triage somebody to a less or more medically oriented program. And what I'm showing on the right side of my slide here is the pre-participation screening guidelines. And the thing to note is that there are pre-participation screening guideline notes for cardiovascular disease, metabolic disease, and renal disease, and not one word about cancer, which means that all of those exercise professionals and PTs out there using these guidelines have no guidance from the American College of Sports Medicine as to how they should triage cancer patients. And so they would triage every cancer patient in the same direction, regardless of the level of risk. That needs to change. There's research that's needed as well. Efficacy trials are certainly needed, but our outcomes need to shift. The 8 cancer health-related outcomes that we were able to document exercise makes a difference in, and the ACSM guidelines are great. It's fantastic to have those that evidence available to us. But in order for us to be able to shift so that exercise becomes standard of care, we need to focus on treatment efficacy. We need to focus on health services outcomes, healthcare utilization, and cost. We also need to start to do more evaluative trials so that we better understand the various different common implementation models for exercise oncology, which ones are cost effective and which ones actually move the needle on healthcare utilization. And of course, we need a lot more implementation science in the field of exercise oncology. I'm delighted to report that I have led a team of researchers on a quest to get approval from Energy Oncology, a national cooperative group, to get approval for a CCBR concept called Exercise as Medicine in Medical Oncology. And for the getting this approval, the great news is now we get to train in R01. But what we are doing in this is recruiting patients with solid tumors receiving infusion-based chemotherapy. And these patients are randomized within practice, oncology practice, and the practices are either randomized to the standard arm, which is brochure therapy, which is the standard of care, or to implementation of exercise as medicine in medical oncology, which starts with implementation facilitation applied to adapt the clinical workflow in order to enable patient assessment advice, referral, and connection to evidence-based exercise oncology intervention by providers and staff. This design is a hybrid type 2 cluster randomized controlled trial. And what we see is that there is a gap in testing effective implementation strategies for improving those clinician referrals and utilization of evidence-based exercise interventions in the setting of medical oncology. The evidence base in exercise as medicine exists primarily for short behavioral interventions, referrals, and treatments, known as experts, in primary care. So we are trying to now translate this into the setting of medical oncology. We also believe that working with NRG Oncology and the CCDR team and working with the community oncology settings that are connected to NRG Oncology, we are getting real world factors that will influence implementation in a setting where 80% of cancer patients receive their care. This is a multi-level intervention. Of course, there is the evidence-based exercise oncology intervention to be delivered by Maple Tree Cancer Alliance. And that's what we think of as the intervention when we think about randomized controlled trials. But there's also an intervention at the level of the treating clinician. There's a change in the clinical workflow in order to help figure out where in the process, from the point of the patient walking in the door and checking in at the front desk to them leaving and seeing billing, where do we do the ask? Where do we advise and refer? How do we connect them to this program without overburdening our medical oncologists? We also see that there is intervention at the level of the care delivery team in oncology practice. So we think that there are things that are happening at kind of the meta level there as well. Our specific aims are to assess whether implementation, facilitation of this Ask, Advise, Refer, Connect process results in an increased proportion of patients that are referred to an evidence-based exercise oncology intervention. Our second aim relates to implementation, and what we're interested in is understanding the mechanisms through which this change in proportion would occur. What is it about our implementation that actually works so that we can repeat it when we try to do this in dissemination and implementing in more clinics? Our third aim is to assess the effectiveness of patient-level outcomes regarding symptom burden. In addition to implementation science work, I mentioned earlier that we have a real issue with workforce development. Exercise professionals are in general not being prepared to work with oncology patients, and this really needs to change. We are currently undertaking a Delphi process to identify the knowledge, skills, and abilities that make exercise oncology practitioners successful. That will lead us to the ability to retool our credential at ECSM in collaboration with the American Cancer Society so that we can get more trainers trained to work with this population. We need to create an easy button as well for the average trainer so that they understand the basics of cancer in a 101 module. We are working diligently to bring Anna Campbell's Can Rehab program to the United States in a licensure agreement with the American College of Sports Medicine. And we are working on developing a textbook for undergraduate programs in exercise science called Essentials of Exercise Oncology. Finally, in the area of program development, we have a directory through Moving to Cancer, which has 1,800 entries. At this point, we have fully searched 15 different states, but we need to do a lot more with mapping of these to understand where the gaps are. We already know that there's a problem in West Virginia, that there's not enough programs in West Virginia, but we need to know exactly where we need to be sending programs. I am delighted to tell you that we have made some excellent progress in getting national fitness chains interested in this area. Lifetime Fitness is the first one to step up to the plate. They have developed online exercise oncology programming, which they are ready to take nationally. So in conclusion, what I will say is that implementation of exercise oncology is going to require quite a village. It is an uphill climb, and I thank you for your attention, and I look forward to your comments.
Finally, I'd like to introduce Neil Iyengar, who is at Memorial Sloan Kettering Cancer Center. Dr. Iyengar is a board-certified medical oncologist and clinical translational researcher, where he specializes in the care of patients with breast cancer. He also holds joint research appointments at the Rockefeller University Center for Clinical and Translational Science and Weill Cornell Medicine in New York. He now holds a faculty position as an associate attending on the breast cancer service at Memorial Sloan Kettering. His research program investigates interventions to improve metabolic health as a strategy to reduce breast cancer risk and mortality. Dr. Iyengar also leads the Optimal Living Program, a novel cancer care model that aims to translate research findings from lifestyle intervention trials into clinical practice during and after cancer therapy.
Thank you very much, Dr. Nelson, for that introduction, and thank you to the AICR and the organizers for putting together this excellent meeting. Today, I'll be talking about targeting obesity to improve cancer outcomes. So here are my disclosures. Let's start with the AICR guidelines to reduce cancer risk. And as we have been discussing through this symposium, there are strong epidemiologic data to avoid obesity and specifically to incorporate exercise and a high fiber, plant-forward diet to reduce cancer risk. But the focus of what I'll be talking about now is the post-cancer diagnosis setting. And the prevention guidelines, I think, are a good place to start, particularly when we're aiming to reduce the risk of cancer recurrence or secondary obesity-related cancers. However, the point I'd like to make here is that we can think about applying a precision oncology paradigm to the application of anti-obesity treatments for improving cancer outcomes. As we have discussed, obesity is associated with worse outcomes for several different types of cancer, but this relationship is complex and is mediated not only by host biology, but by tumor biology and type of cancer treatment. For example, even amongst the cancers in which obesity is associated with worse outcomes, there are some tumor subtypes in which the effect size is far greater than others. Additionally, we know that the type of cancer treatment can be differentially impacted by obesity. As has been highlighted in this symposium, the association of obesity with cancer mortality is different for patients treated with immunotherapy versus hormone therapies, and even specific types of chemotherapies, for example, taxane versus non-taxane containing regimens. So I think a critical research question is, in the post-diagnosis setting, can we identify obesity treatments that have the highest potential for anti-cancer effects based on host, tumor, and treatment factors? We also know that the mechanisms linking obesity to cancer progression are multiple and complex. Fortunately, several studies and many of the investigators here have shown that lifestyle interventions such as exercise and diet have pleiotropic effects that favorably impact multiple pathways that are shown here on this slide. But we're also learning that some tumors are more dependent on specific obesity-related pathways, and that we can preferentially target some of these pathways more predominantly by potentially selecting specific types of lifestyle modification or even metabolically targeted medications, such as those that target insulin or lipid signaling. I've previously shown our data with regard to breast adipose tissue inflammation, whereby this adipose tissue inflammation is found commonly in obese and overweight individuals and is associated with worse cancer-related outcomes. Here again, you can see that adipose tissue inflammation, which is detected histologically by crown-like structures. This cartoon is showing you a dead or dying adipocyte, that's the brown cell, surrounded by these yellow activated macrophages, and below you can see the CD68 and H&E stained sections. The presence of these crown-like structures, which signify adipose inflammation, are associated with worse outcomes for patients diagnosed with breast and several other types of cancer. But this is just the tip of the iceberg. The histologic finding of adipose tissue inflammation indicates multiple other locally disrupted mechanisms. In the setting of obesity, and especially adipose tissue inflammation, there are hundreds of differentially regulated genes in the tumor microenvironment. And I don't have time to show all the data in this session, but we have observed that gene signatures of key immunologic, metabolic, and hormonal pathways are modified in a tumor-promoting manner in the setting of obesity and adipose inflammation. And by the way, I'm a breast medical oncologist, so I show a lot of breast cancer-related data, but we know that adipose biology plays an important role in several other cancers. For example, in ovarian cancer, the omentum serves as an adipocyte and lipid-rich metastatic niche that is accentuated in the setting of obesity. Additionally, our group has reported that adipose tissue inflammation occurs in multiple fat depots and is associated with the growth of several cancers. And many of these neoplasms are typically embedded adjacent or within the fat pad. So elucidating the biology through which obesity drives cancer growth is important as we start thinking about wielding lifestyle or metabolic interventions in a precision approach to target specific pathways upon which any type of cancer, specifically the obesity-related cancers, may be more predominantly dependent. This is, of course, the paradigm used in precision oncology drug selection. However, the difference is that lifestyle interventions typically can have multiple beneficial effects. For example, we know that in addition to its systemic effects, exercise is associated with reduced adipose tissue inflammation independent of BMI. Here you see less breast adipose tissue inflammation in exercisers versus non-exercisers. And this association applies even to those who are not classically obese by body mass index. There have been a number of randomized controlled trials that have established the feasibility of weight loss interventions in cancer population. And here I'm showing breast cancer specific trials in the adjuvant setting. In terms of cancer outcomes, I'll point out two seminal studies, the top two studies on this slide. The Women's Interventional Nutrition Study, or WIN study, randomized 2,400 breast cancer patients to a low-fat dietary intervention or usual care control group. There was an average of about 4% weight loss and a 24% reduction in breast cancer recurrence in the intervention arm. However, in the Women's Healthy Eating and Living Study, the WELL study, which randomized about 3,000 women to a high fruit and vegetable low-fat diet arm or a usual care group, the participants did not lose weight and there was no difference in rates of breast cancer recurrence. So perhaps weight loss is one of the drivers of the improved outcomes seen in the WINS trial. We'll soon have more data to address the question of whether we can move the needle on cancer outcomes with weight loss interventions. This is the multi-center BeWell study through the Alliance led by Dr. Ligabel, which is testing a health education and weight loss intervention in overweight and obese patients with stage 2 and 3 breast cancer. In addition to losing weight or not, it appears that the rate and the amount of weight loss matter. Our group conducted a prospective feeding study, including deep phenotyping, in 10 obese postmenopausal women who consumed a very low-calorie diet, most of them under inpatient monitoring, for about 6 weeks. Participants lost about 10% of their baseline body weight within 6 weeks, so this is pretty rapid weight loss. And although we saw an improvement in circulating metabolic markers, including lipids, insulin, and inflammatory markers, we actually saw an increase in adipose tissue inflammation in the abdominal subcutaneous fat. And you can see that in the line plots in the middle of the slide, that's panel B here. And in panel A, you can see representative pre-intervention and post-intervention fat pad biopsies. This is abdominal subcutaneous fat, where in the post-intervention biopsy, you can see greater numbers of crown-like structures. These data support additional observations in prostate cancer, where rapid weight loss from caloric restriction in the neoadjuvant setting may accelerate tumor cell proliferation. And I want to get back to this precision intervention concept where we may be able to emphasize specific lifestyle interventions, such as a type of dietary pattern based on the setting. In the adjuvant setting where we're trying to prevent recurrence, a plant-based diet is of interest just as it is in the risk reduction setting. Here you can see data from the Nurses' Health study where a healthy plant-based diet was associated with improvements in circulating metabolic and inflammatory markers, including leptin, CRP, and IL-6. In addition, plant-based diets have been shown to reduce joint pain in patients with osteoarthritis. That's shown here in this 6-week clinical trial. Joint pain is one of the top reasons for discontinuation of adjuvant hormone therapy with an aromatase inhibitor in breast cancer. So an intervention that could improve inflammation, metabolic signaling, and thereby improve cancer outcomes, while also improving quality of life and adherence to hormone therapy, would really be incredible. And this is a hypothesis that we're currently testing, specifically a plant-based diet plus exercise in postmenopausal women with hormone receptor positive breast cancer receiving aromatase inhibitors. This trial is about 50% accrued at this point. I also want to highlight that there may be other dietary approaches which we should or which we might include in our treatment armamentarium. breast tumors find ways to enhance insulin signaling by lowering or eliminating the cellular threshold for PI3 kinase activation. PI3 kinase is involved in cancer cell proliferation. Recently approved PI3 kinase inhibitors like alpelisib block the intracellular action of insulin on the liver and skeletal muscle, thereby creating a transient state of insulin resistance. Therefore, hyperglycemia is an expected on-target effect of PI3 kinase inhibition, especially in subjects with baseline insulin resistance or beta cell dysfunction. Hyperglycemia was in fact reported in over 60% of patients treated with PI3 kinase inhibitors, and more than 1/3 of patients treated with PI3 kinase inhibitors experienced severe hyperglycemia. Paradoxically, that hyperglycemia can reduce the efficacy of that treatment for PI3 kinase mutated tumors. So in this very specific setting, that is PI3 kinase mutated breast cancer, we're testing a ketogenic diet versus low carbohydrate diet versus SGLT2 inhibition based on a preclinical rationale to improve hyperglycemia and ultimately improve the anti-tumor efficacy of this treatment. This is a dietary strategy that I would not typically recommend in the prevention setting, but it might be useful in the treatment of specific tumor subtypes. So what can we tell our patients right now? Well, here are the ASCO guidelines, and I think we're all pretty familiar with these, so I won't go through them in detail, but the gist is to maintain a healthy body weight through physical activity and a plant-forward diet. Of course, I've just shown you that we have much more on the horizon in terms of making these recommendations more precise and specific to the setting, and hopefully more effective. These are additional resources that I find useful when I'm treating patients in clinic, and I'll leave you with these. I always advocate for a clinical trial when available. A lot of centers have integrative medicine programs that offer diet and exercise programs. Of course, the AICR is a wealth of information for clinicians and patients. The Live Strong and diabetes prevention programs are widely available to patients. And in some of our more severe cases, such as class 3 obesity, or where lifestyle modification is not feasible or not successful, medical or even surgical therapy overseen by comprehensive weight control clinics can be considered even for our patients with cancer. So I'll end there and thank you for your attention and interest. Thank you.
Okay, that was great. So now we have Melissa, Katie, Wendy, and Neil on, and Erik and I are going to moderate discussion. Maybe we'll just start if there were any people on the panel who want to sort of make comments of the first hour, and then we have a bunch of great questions that we'll go through as well.
Well, I'd like to jump in. You know, the one thing that I found really interesting is Melissa's data about the map of obesity throughout the United States. And I want, and also make the observation that Elena Lattis basically had the same sort of issue brought up in her talk yesterday, which is this perception of overweight and obesity is tough in under-resourced areas where food security is an issue. So we're battling issues of food security, but then battling these issues of increased rates of obesity. Having done a survey throughout our state in Alabama, which is kind of in the war zone and epicenter of obesity, we found that 80% of our populace is either overweight or obese. However, when you tap into that segment that's overweight and obese, and you ask them, what is your perception of your body weight status? The people who 40% of those who are overweight say, I'm just about right. In fact, 14% of them say, I'm underweight. What are you kidding me? And so there's a perception issue here that we really do need to deal with.
And we need national, organizations to help in that arena. And it seems as though we almost need global programs that can really enforce what a healthy weight is. So just, I thought that those data were so interesting.
Any comments on that? Yeah, I agree. I thought that was great. That was a good analogy in that pick up there. Maybe we'll start with maybe Katie will ask you some questions that came from the audience. And the ACSM cancer exercise training certification is great intro to the exercise needs of cancer survivors. Maybe that could be more available to healthcare folks as more of an educational component.
Yeah, so I'll kind of clarify a little bit. It turns out that you never want to sort of reveal a failure in a setting like this, but when it's true, it's true. We've had that certification on the market since 2008, and there are fewer than 1,000 people around the world that have taken up the call. So clearly, our bar was set too high, too low, too sideways. I don't know. But we're in the process of redoing all of the thinking about certification. And the great news is that we've partnered with the inimitable Anna Campbell, who has developed something called Can Rehab, which is the world's best training program for exercise professionals and healthcare professionals around exercise oncology. And ACSM is licensing Can Rehab. And that will include something akin to the Cancer 101 idea that I spoke of in my talk, because we don't need, in the same way that we don't need every trainer to be ready to do cardiac rehabilitation, but we do need all trainers on the gym floor at the YMCA to know CPR and to know signs and symptoms of a heart attack, right? So think about that in terms of what is the triage that you want for the cancer patient. You want to know that they have cancer. You want to know where they are in their treatment. You want to know about their immune compromise. What else do you want to know? So if you had to give a 101 to the average, trainer on the gym floor at the Y, what would it be? So we're working on that, and that's an active area of work at ACSM.
There's a question, I guess, and it really goes for everyone. And it comes up a lot, so I'm going to ask it and spark the conversation. But what about prehabilitation for patients, both dietary intervention and exercise?
I want to take this because I want to give a plug for a talk that's coming in one of the satellite sessions. Dr. Daniel Santamina does some really cutting edge work in the area of prehabilitation in cancer patients. And Nigel, you may have to come on the screen to remind us whether that is on the 10th or the 17th. I believe it's the 10th at noon Eastern. And so there is robust evidence in colorectal cancer in particular. The evidence in breast cancer is not quite as strong, but in colon cancer, we can show that we can actually get people out of the hospital quicker. We can prevent, I do have confirmation that it is the 10th. So there's that, but colorectal cancer, there's really, very deep evidence that prehabilitation is valuable and has the kind of value that healthcare systems and payers should be paying attention to. It is the kind of intervention that changes healthcare utilization and cost in a way that it should be paid for. It may actually be sort of a leading indicator for us in exercise oncology. But good prehab is not just exercise. Prehab is going to be exercise, it's going to be diet, and it's going to be psychological support all at once. Anybody else?
I'd like to make a comment about that in regard to childhood cancer patients. We've actually had some challenges in trying to introduce prehabilitation in some of our frontline trials and finding that sweet spot where families who are overwhelmed with the diagnosis and all the information that's being provided and adjusting to diagnosis, treatment, et cetera. Sometimes it's been difficult to handle. So we've been scaling back, but moving forward because it's just a critical time to address families who may be more receptive to a lifestyle change, and they're actively seeking what can they do to help their child. We've discovered in long-term follow-up, as we're discussing these health risks, and long-term follow-up, I mean that in our program, they're 5 or more years from their diagnosis, they become complacent again, and it's difficult to undo the behaviors that have reemerged. And so I think it's just absolutely critical to maintain that that level of support early in the treatment course and the cancer care continuum to hopefully sustain this into long-term follow-up.
Yeah, I just want to interject that we've done some pre-surgical trials, and it is, like as Melissa says, very difficult. This is a time when families are just reeling from a diagnosis, and it's hard to take on one more thing. However, this is where trials really do need to be done. That being said, we've known for years that being adequately nourished and not coming into a diagnosis being malnourished is one way that you could sustain the various treatments that we do give people and have superior outcomes.
I'd also like to add a comment on this. I think one of the things that may be an interesting setting in which to perhaps have more time to test some of these pre-surgical interventions are when we think about the spectrum of pre-malignant lesions to invasive lesions. And particularly in breast cancer, this tends to be more feasible, of course, because we're talking about in situ carcinomas or even atypia that can then predispose to invasive carcinomas. But as Wendy and Melissa have mentioned, once the invasive carcinoma diagnosis has occurred, particularly in breast cancer, in our experience, it's been very challenging. There's a 2-week window, or sometimes even less, oftentimes for intervention before surgery. So I think if we start thinking about intervening at the pre-malignant stage, this may give us some more opportunity.
I agree with you. I mean, some of the issue is we feel like there's a short window because we don't really have the data to say, if you wait for 6 weeks, it's okay, which it really probably is, or it really is. And you will then have there's some improvements in outcomes, whether that's, and Katie mentioned colorectal cancer, faster time out of the hospital, shorter time to flatus, less pain medication usage, et cetera. So, but the data needs to catch up to that, because then it's easier to say, we really do need to pause so we can do that, because at the end of the day, there's going to be a better outcome and not compromising overall recurrences or survival.
Absolutely. I think there's competing interests there. It's certainly the data needed to show the natural history, and I agree with you, it probably doesn't so much matter for outcomes in term, and perhaps outcomes can be improved by extending that period and intervening. That being said, I think there's also the other challenge is from the other side. There's a great deal, at least at our institution, there's a great deal of patient interest in intervening with traditional interventions as soon as possible. And so I think I agree with you. I think if our research priorities are to show that perhaps extending that time and intervening may improve outcomes, I think that would provide the convincing data that we need.
I'd like to make
say that the places where you might be able to do this easier would be in health systems that aren't like the US, perhaps in Canada, where they take a much more measured approach to cancer. And so for the Canadian researchers who are out there, and I know you are, this may be a really good sweet spot where you could contribute to the field.
And I think some of what Katie presented, the data is very pertinent in that you're not just giving a physical activity or exercise prescription, you're really addressing more globally psychological status and its impact on function and performance. And I think if families and patients can take it in that context, maybe it will resonate more as they are orienting to this new world, with cancer diagnosis and treatment.
Yeah. So I just want to sort of put on both of my hats at the same time. As a cancer caregiver, my wife had, head and neck cancer now 5 years ago, and at the same time as a scientist, and kind of think about that. What we know is that we do what they tell us to do. And if the doctors were to have told us to stand on our heads and spit nickels before Sarah's surgery, we would have done it. So, if it's there, I think that there is something to be said for the idea of, prehabilitation is part of what they do in some orthopedic settings. And, if it's just, this is what we do, this is how we do this procedure, then I think patients will do it. That said, I know what I know. And Sarah's diagnosis came 1 month before her first surgery, before her first intervention. And we just went home and panicked. And I did nothing. I did nothing because nobody told us to do anything. And I kind of, it wasn't until she had symptoms and I went, oh, wait, I can help with that, So I think that there is protocolizing this, making it, and I think you're right, Wendy. I think that one of the reasons why Daniel Santamina's work is happening the way that it's happening is because it's happening at Prince Margaret Hospital in Canada. So I very much agree with you that we, closed systems, Kaiser, Geisinger, Mayo, maybe those would be, easy targets for trying to get something like this going.
Yeah, I'll echo that. When my mother-in-law was diagnosed with leukemia, the oncologist, the prehab that the oncologist prescribed was go out, eat whatever you want, get fat because you're going to lose all that weight during chemo, which, obviously not where we're coming from, but I think there's still this cultural piece or this historic piece from the past where that is still kind of on the ground. This is what oncologists are still recommending, which is a little disappointing. So everyone in the audience, now that you've learned everything in this conference, go out and beat the bandwagon. Similarly, Dr. Iyengar, maybe you can comment. So you showed that with rapid weight loss in your breast cancer patients, anyways, you get an increased inflammatory signature, at least locally. Maybe in the context of prehab or at any point during the treatment, do you think weight loss might be problematic if you're promoting this inflammatory signature?
Yeah, that's a great question, Erik. I think, we're learning more about the ideal rate of weight loss, and there's certainly plenty of safety data to suggest that a slower or moderate rate of weight loss, the data that I showed was essentially 10% weight loss within 6 weeks. And we did that with purpose. It was essentially to ask the question, can we, rapidly intervene, especially when we're talking about these shorter intervals like the pre-surgical setting. I think to answer your question, I think right now the data essentially tells us that we don't really want to exceed more than 2 pounds per week of weight loss, and even 2 pounds is a bit on the aggressive side. I typically aim for 1 to 1.5. Interestingly, though, what we saw there was that the systemic profile was uncoupled from the local profile. And what that means for tumors that are embedded in a fat pad, we're still learning. And I mentioned, but didn't show the data, but there are some small studies in prostate and renal cancer, whereby rapid weight loss is associated with higher grade or more aggressive tumors. And so I think those local effects are very important. To get back to the original, the comment you made before about, oncologists recommending weight gain or things like that, I think you're right. I think that the field, well, at least what I'm maybe this is too optimistic, but I think the field is starting to shift. And I think clinicians, because of conferences like this and work like the investigators throughout this symposium, I think clinicians are starting to recognize that those kind of recommendations are sort of unfounded. And certainly there's data to suggest that weight gain is common during the treatment of several cancers. So I hope that paradigm is shifting.
This question, I'll start with Wendy, and others obviously can weigh in too. How would dietary guidelines change for individuals who are not obese, and particularly if they are underweight to start with? What should be the recommendation for those?
Yeah, obviously there are a proportion of cancer survivors who are underweight, and so according to Greenlee, who did a really nice study, I think in 2016, this is a fraction of people who are around 7 to 8% of cancer survivors. So clearly in the minority. We know that most of the cancer survivors are overweight, overweight or obese. So that's who our target is right now. But there are this proportion who are underweight. Obviously, those people need to, if you're underweight, you have BMI that's 18.5 or under 18.5, you should be working to gain some weight. Those who are normal weight, BMI 18.5 to 24.9, really should be following the guidelines, the rest of the guidelines, but then keeping a very vigilant eye out for weight gain, because still weight gain is not recommended in that population. Stable weight is, and many forms of treatment do cause weight gain. So you have to be vigilant there. And but if you're underweight, follow and a normal weight, follow the guidelines with regard to dietary pattern, alcohol, and then just keep an eye out for for that weight gain. So I hope I answered that question.
Yeah, I'll just do a follow-up related to that, and others can jump in too, because another similar theme is sort of the thin out. The question was the thin outside, fat inside phenotype should not be overlooked, where BMI may not be in the normal range, but elevated risk exists due to large visceral fat mass. The thin sarcopenic BMI is not applicable to all ethnicities in the United States either. So it sort of brings also the issue of how should we be using BMI as the measure, and anyone can comment on that.
Yeah, I'm happy to sort of jump in there real quick and say that we've shown that this adipose tissue inflammation occurs in a third of normal weight individuals. We also know from the Women's Health Initiative that women, postmenopausal women with a total fat mass percentage of 33% or greater, despite having a normal body mass index, have double the risk of developing invasive breast cancer over a 16-year follow-up period. So certainly this is a high-risk population. Now, whether weight loss benefits this population is currently under study, but I agree that BMI is not the best risk stratification tool for metabolic health when you're sitting face-to-face with patient, and definitely varies by ethnicity. We also know from studies done in Taiwan and South America that patients with lower levels of BMI and other ethnicities actually have larger adipocytes and more inflammation and greater insulin resistance at lower thresholds of BMI. So certainly we do need to be more specific when we're sitting face to face with the patient.
Yeah, while that is true, the one thing is that it is the best, BMI is the best measure as far as being able to cover a population. It's cheap. It gives us fairly good data. It could be supplemented with waist circumference to somewhat nail down where those fat stores are. But you're not going to get a DEXA machine out to those under-resourced areas, and that's where we have our biggest problem. So it's a hard issue to tackle.
Definitely, and I think that this is a setting where novel biomarkers may be of interest as we start to think about a lot of the data that was shown at several sessions during this symposium. If we remember back to the microenvironment session, there are a lot of genomic markers that are easily available from surgical samples, for example, after a patient undergoes cancer surgery, that could potentially be used to metabolically risk stratify a patient, and maybe in the future used to guide interventions during or after cancer therapy. But I certainly agree that it's a challenge to find a tool that can be applied more broadly amongst populations.
May I ask a question, just that because our experience in pediatric population is sometimes so different, especially if they're very sick as they enter their treatment course. We're focusing more on mindful eating. You know, the families are delighted the kids are eating anything, and these terrible habits after they, you know, like an ALL survivor who's been on steroid pulses and has all sorts of cravings for unhealthy foods. We see that persist into long-term follow-up. So some of our interventions are really focused on the family and helping them understand nutrition and how to get through this challenging period without saying, just let them eat anything they want to, you know. And so I just cringe walking into a room with a kid with a bag of chips, but that's all they've been eating, you know, since they've started their ALL induction. So do you experience that in adults? And it's similar to the doc saying, oh, just eat what you want to eat, you're going to lose weight. I think that we have those same challenges, but they really do affect these survivors long term.
You know, the one thing is that with kids, I think the problem's accentuated because that's when eating behaviors are formed, and children realize that if they, you know, they can press their, any child can press their parents' buttons, right? But in a situation where that child is sick, you're willing to give them anything because, of course, they're the most important thing in your life, right? And the child, you know, the child sits back and he or she realizes that they, you know, if they hold back, they can get chips, they can get, you know, Twinkies. And so they're no fools. So the problem's just accentuated, and the parents really do need to hold their guns and promote a good diet during that time. It's not a time necessarily to let down all the defenses and to say, eat whatever you want. It's important to eat a balanced diet during that time point.
So just following up on that, Dr. Hudson, you mentioned one strategy might be mindful eating. So my question is, you showed data that childhood survivors are kind of at an increased risk of cardiovascular disease in later years of the life. So how do you get that knowledge across to your child patients who, you know, at least when I was a child, I thought I was invincible. So how do you go about structuring their lives or informing them so that they can make the right choices or are motivated to make the right choices?
So our counseling obviously is developmentally appropriate, you know, when we introduce these concepts, and importantly, everything we're doing for these younger patients is really focused on family infrastructure to support healthy eating and physical activity, et cetera, and not smoking. So we address the family, but as the survivor really becomes of age and is responsible for their own health behaviors, we provide that counseling in the context of, you've had this cancer history, you've had specific treatments. Some of these treatments we know can affect your long-term health. And based on what their risk profile is with their specific treatment, we can be much more specific about, you've had a red medicine that we know has been linked to heart problems later in life. And as we discuss what those vulnerabilities may be, we circle around immediately to, this is your role to play. You know, as your doctor, I'm going to screen. As your doctor, I'm going to be sure that if you have any other modifiable clinical issues like high blood pressure, et cetera, dyslipidemia, we're going to attend to that. But your job is to be sure that your health behaviors are the best they can be to help preserve your heart health, et cetera. So we use that paradigm of it's a collaborative relationship. This is what I'm doing as, you know, the clinician working with you, but this is what I need you to do. And then we're looking at the family to provide, you know, a healthy environment with food and whatnot, and and of course, pulling in resources like dietitians and other rehabilitative services that help us get them the information they need to implement these types of behaviors.
So Melissa, I'm curious to get you and Neil to talk, and Jeff to talk for a minute about, you know, the training of oncologists, the training of clinicians, and, you know, what you all heard and what you think could be done in the training of clinicians to help with. I think that, you know, if they told us to stand on our heads and spit nickels, we would have, you know. So what did you hear in your training, and what do you think could be done to shift what happens in fellowship, because so that we don't have docs say, go home and get fat, like Erik's grandmother heard, or, you know, eat anything you want, you know, or sit on the couch because, you know, cancer is hard, you don't need to exercise. Can you all reflect on that at all?
You want me to start with pediatrics? I think we're poorly trained, you know, and there are docs who are all about the cancer and we're going to get those cure rates up and we're going to get you through this course of treatment. And they may ask if you smoke, but there's not consistent primary care health messages addressing behavior. They may just be addressing side effects and this is the next therapy that's due in your calendar. The problem that we see now in long-term follow-up, again, by the time they're 5 years out and they're attending what is really a primary care focused clinic looking at all aspects of health, that's when the messages occur. But even then, oncologists do not have that training. We are seeking collaborations with nutritionists and exercise physiologists and other rehabilitative services to get those messages. So I realize a deficiency, and I agree 100% with you. We actually see it a lot with immunizations. If those docs in the treating clinic had made a comment about get your COVID shot or your HPV shot, it would have happened. If we do it in survivorship, when we don't have that same relationship of you saved my child's life, it's not as likely to happen. So I think those same health messages can be quite impactful if they come from that doctor who is treating you and taking you through this horrific cancer course.
Yeah, I mean, I'll echo Melissa. It's not something we teach very well or certainly have been taught in training. It also, you know, it leads to the problem that a lot of clinicians have, which is, you know, at the end, we still have a limited time for each visit, right? And there's a lot to cover. My wife's a primary care doc. She's supposed to ask about seatbelts each time. Seatbelt saves zillions of lives. You just can't do it, you know, in each visit or for each patient. And similarly, to be able to get to some things, especially if people are have multiple issues, other issues going on. I think most of us, at least, you know, on this screen, are fortunate to be in larger centers where we have the resources, that we have great nutritionists, we have a center that works on complementary therapies, has someone specifically trained to do exercise therapy and consultations for patients. That's not the reality, even in the United States, for most community practices. And so it's really trying to, and I think, you know, Katie, part of your effort with moving through cancer is really to how to get that the access for, you know, where the vast majority of patients are treated, which are not in large academic centers.
Yeah, I'll just echo those comments and add two things. One is that, yeah, the training of, I would say, oncologists is poor, although I do think that medical school curriculum is shifting to at least introduce the importance of these concepts, not in the type of in-depth training that is required to actually carry out these interventions, like a nutritionist or an exercise physiologist. But I do think that the field is shifting a little bit so that MDs are trained and clinicians are trained to recognize and counsel on the importance and set up that collaboration. And I think that's happening because more and more lifestyle intervention trials are reporting outcomes that is sort of in the language of the oncologist, if you will. So a lot of the patient-reported outcome work is really important. A lot of the tumor-targeted cancer outcome endpoints are very important and pick up interest in oncology circles. So I think that work that many of us are doing is really incredibly important. And the second piece, and I love the work that you're doing, Katie, with regard to implementation, is, you know, when I go to continuing medical education seminars and give lectures about lifestyle interventions, which, by the way, is a fairly new thing because those are usually all drug talks. But the common response from people practicing in the community is, as Jeff mentioned, we simply do not have access or reimbursement for those types of resources. And I think that's still a challenge. And I'm glad you're working, Katie, to overcome that challenge.
I just want to reflect that we have actually mapped the first 15 states in the Northeast corridor, using the Moving Through Cancer directory. And I can tell you that I can confirm that we are really just missing exercise oncology programming in rural settings like most of West Virginia, but that there are, 6+ cities of 20,000 or greater on the Eastern Seaboard that do not have any exercise oncology programming. So even in urban settings, we cannot count on the idea that there is programming that is easily available. And that's just exercise. That's not even, the nutrition question is looming.
That
as
goes
well.
double for nutrition. So,
Right.
yeah.
I think, right, like ultimately the work that the AICR supports and other trials, like once the evidence is in place and insurance companies are showing like, wow, outcomes, and therefore the amount you have to pay per patient are much less if you pony up for a dietitian or an exercise trainer. So, it might be a long-term goal, but I have faith that the dollar will speak. And once we have evidence that these things will save money in the long term, then insurance companies will start reimbursing.
Yeah, I wish I had your sense of, optimism, Eric, because even, I know that Katie's done some of these trials too. We've shown efficacy. We've shown that they can reduce costs. It still is a barrier. And so how much evidence do we need? So, it's a barrier. It is a definite issue. So yeah, people will pay thousands of dollars for chemotherapy. They will not pay hundreds of dollars for any kind of supportive care. So that's where we are.
Yeah, we've actually asked. I have work that's funded by AICR, and it's an Alexa-based, smart speaker supportive care platform. And we actually have asked, would you pay for this app? And they said no. So they love it, they want it, but they think it should be provided to them.
Shifting gears a little bit, that was a great discussion but there's been a lot of questions about types of diets, particularly low carbohydrate, ketogenic diet. Neil, you mentioned that we would typically not recommend diets such as the ketogenic or low carb diet. Sorry. Can you shed more light on that? And then I'll add to that. And we talked about a little yesterday, time restricted eating. So I don't know, Neil, Wendy, or others can also add to how to think about those various diets.
Yeah, the differentiation comment that I'd like to make is, right, the research setting versus the clinical recommendation setting, right? And so when we're in clinic talking about diet and referring patients to nutritionists, for example, I typically don't endorse a very specific or fad diet, if you will. I think low carbohydrate diet is can be a general dietary pattern that is reasonable and useful. But when it comes to something like the ketogenic diet, I'm still waiting for the data before I start saying that this is something that one should follow or consider following. And I think there are very convincing preclinical and even observational data to support that type of a diet for very specific types of tumors. But the trials have to be conducted, and we need the data to be able to recommend those diets. So I would say, and I definitely would love to hear Wendy's thoughts on this, but I think generally speaking, when I'm talking to a patient, I try to focus more so on more dietary patterns, what the overall outlook of their diet is and how that fits into their lifestyle, and then try to modify that or make it even more precise based on what their specific risk factors are, be it heritable risk factors or environmental risk factors. But beyond that, I just don't have the data yet to be able to tell a patient you should consider the keto diet here or any other type of fad diet for that matter.
Yeah, I echo what Neil says. We know the guidelines for overweight and obesity clearly stated there is no, there are no differences in weight loss between the ketogenic diet versus the low fat diet in the normal population. We also know from Cindy Thompson and Henry Thompson's work in cancer survivors, there is nothing that's different except for triglycerides. So this hype about the ketogenic diet is really over exaggerated, though it might be good, as Neil says, in some subtypes of cancer, in brain cancer, where you're talking about the ketones passing the blood-brain barrier. It might have some applications there, but broad scale, we don't have the evidence now.
Similarly, there was a question from the audience. In the current guidelines, is there any breakdown of how much fruit versus vegetable consumption you should be advising your patients to have?
I can take that. The vegetables have less calories than fruit. They tend to be more energy dense as far as the ratio of phytochemicals and fiber. So we tend to promote vegetables over fruit.
I'll throw this out to everyone. So, a lot of the AICR guidelines and WRCF, I'm probably got wrong, and ACS guidelines are sort of general guidelines, for cancer survivors. But, we know that biologically each cancer is different. So how do we sort of reconcile sort of what we generally think about is good habits and lifestyle for other diseases, but specifically if you're a head and neck patient versus a lung cancer versus breast cancer, how do we sort of figure that out for patients?
I'll jump in and say that, I really have thought a lot about this because of thinking about implementation. And I think many of you know, I've written a popular press book called Moving Through Cancer. And for that book, which was intended to translate the ACSM guidelines for the layperson, the big question was, how do I do exactly that, Jeff? And what I think a lot of us have done, and I think is appropriate, is it's really much more about what the treatment is than what the tumor is. That, it's really about, is the person receiving an agent that has the following action or that action? And, what's going on with radiation? So that helps because it means that it's no longer, 20 types of cancer, but there are, maybe 4 or 5 types of treatment that we can focus in on. It's still a question. Because there are specific guidelines and things that I would tell people to do in, recovering from their surgeries, as opposed to during their radiation, as opposed to during this type of chemotherapy versus that type of chemotherapy. So, but I do think that organization of things helps us to implement.
I would echo that. It's really treatment exposures that drive the adaptations that we have to do with our performance interventions and activity interventions. If they have acute neuropathy or persistent neuropathy or proximal muscle weakness, we have to adapt and adjust to meet them where they are. And it typically is a very specific treatment exposure or some deficit that may impact their performance related to their primary cancer. If they've had a brain tumor and they have hemiplegia or something to that effect.
I would just add that, I sort of view this as optimistically that we are getting more data to support perhaps more precision approaches in specific scenarios. I do think that there are scenarios where the more general guidelines are actually very, very applicable, particularly since we know that this kind of healthy eating and exercise and weight loss are helpful for a number of other comorbidity and secondary endpoints beyond cancer that our cancer patients are actually more at risk for because of their treatment. But when medical oncology was nascent, as many of you know, I mean, the same chemotherapies were used for multiple different tumor types. Now we're in a space where we have precision targeted therapies, and we have hundreds and hundreds of different therapies. And I think perhaps, and maybe not to that degree, we are starting to see some differentiation in terms of the precision of lifestyle interventions. We now know more about the differentiation between something as simple as resistance exercise versus aerobic exercise. And similarly, we've been talking about settings where something like the ketogenic diet may be helpful and where it may not be helpful. So I think we're generally going in that direction, but we have plenty of evidence and data now to support the guidelines for helping our patients.
Flipping things around a little bit, there was a question about cachexia and so the opposite of obese patients. Are there any specific dietary guidelines or exercise guidelines for those who are underweight or cachexic or have other underlying issues that may prevent them from sort of a traditional aerobic exercise approach?
And then Katie, exercise is a huge component and there's a lot of work that's done. So I'm going to let Katie address that. As far as nutrition, nutritionists have been banging their heads against the wall for cachexia for many decades, trying to find the holy grail. Where can we, what kind of therapy could we give to stop this beast? And once cachexia starts, it is very difficult to be able to intervene. There are some, obviously there's some pharmacologic agents like Megase, which improve appetite, but those also result in huge gains in fat mass that may I'm not sure that that's necessarily what we want to be gaining. Yes, it shows up on the scale, but it is fat mass primarily that is being gained there. There is some interesting work in omega-3 fatty acids. However, at this point in time, once cachexia starts, it's difficult to intervene and to show effect with dietary interventions. There is a Canadian researcher, Carla Prada, in her lab, who is doing some work in this area. Vicky Barakos, these are the leaders in the field, Eduardo Barrera. However, again, it's fairly, the findings are less overwhelming than we really would hope in this area. It's a hard issue, and I'm handing it off to Katie.
Yeah, so I would place the evidence base about exercise and cachexia in early days. There are some reviews, there are some very small trials that have been done, but I think that there's a continuum, Erik, that is from what is exercise doing to body composition, which is not the same as cachexia, and all the way to, okay, are we approaching cachexia? And so the work that I'm most excited about in my own shop is preclinical work that we're developing to try to understand where the tipping point is, where in the process towards cachexia do we need to catch things and offer an intervention, whatever that intervention might be, in order for it to stop from going all the way, tipping over into full-blown cachexia. I think that is of interest to a lot of people. So I think that there is this is an exciting time in cachexia research. I think it's an exciting time in cachexia research in part because a lot of money is being thrown at it as well. So let's hope that in a few years that bears some fruit.
I just want to interject because we in one of our and this may be just too early for prime time, so I'm going to qualify it with that. In one of our pre-surgical trials in men with prostate cancer, we invoked a low-calorie diet among men who were overweight and obese. The surprise to us was we found that the men that lost the greatest amount of weight, and we thought, oh, these are the stars of our program. They lost weight at a very rapid clip. And unfortunately, and we had hypothesized that those men, we would see decreased Ki-67, decreased proliferation rates in those men of their tumors. What we found was the exact opposite. In the men that lost the greatest rates of weight loss, we found that Ki-67 actually increased. It was the men that lost modest amounts of weight, around 3/4 pound to a pound per week that we saw the downturn in Ki-67. So, when we promote weight loss, it could be a two-edged sword here. And there was a marker, cathepsin L, CTSL, that was released, and that marker is linked with cachexia, sarcopenia. And is this a harbinger? Is this molecular marker kind of one of those harbingers or early signs, tipping points that Katie alludes to for cachexia? I don't know, but it was really interesting to us what we found.
I think it'll be interesting and this gets a little bit at Neil's work too, right? Like, how chronic is that, right? So if you followed those patients that lost the dramatic amount of weight longer, does it resolve and ultimately get better, or is it just always that rapid weight loss bad? And then also you add in another layer of like, well, rapidly dividing cells isn't necessarily a bad thing if those patients are going to be hit with a chemotherapeutic that's targeting that. And there's, at least preclinically, there's evidence now that you can reawake cells, get them to proliferate, and then hit with chemotherapy. So I think there's lots to be done in this space, and it's not just a easy, lose weight kind of solution. We need to be cognizant about all these different factors.
Yeah, I agree, Eric. Perhaps not in prostate cancer where chemotherapeutics are not used too much, but maybe in other cancers.
Shifting a little gear to maybe some prevention, but specifically thinking about patients who have underlying cancer genetics. This is a question from the audience. And how what do we know about and how do we advise in terms of diet and exercise and other lifestyle factors for people who have known genetic predispositions, whether it be Lynch syndrome or BRCA mutations or others?
Yeah, I can jump in there. So, for adults with genetic syndromes, for example, BRCA, we do know that obesity is associated with an even earlier age of onset for some of these genetically mediated cancers. And I think that's an important observation for our young women, for example, who are grappling with when to do risk reduction surgeries if they so choose. And so knowing that perhaps avoidance of the obese state or metabolic dysfunction may give some more time, I think can be an incredibly important finding for these patients. We heard yesterday from Dr. Brown, Christy Brown, during the tumor microenvironment session, that the intersections between insulin signaling, adipose tissue biology, and DNA damage in patients with BRCA mutations may also contribute to the onset of these cancers, perhaps earlier, or even secondary cancers as well. And so I think there's both a scientific rationale. Certainly the driver of these cancers are their germline genetic mutation, but I do think that there is a scientific rationale, certainly, to incorporate lifestyle interventions to either attenuate the time course of the onset of these interventions and potentially to improve outcomes in this setting.
Yeah, I mean, I'll weigh, specifically GI-related predisposition cancers, particularly Lynch syndrome. I mean, there are data supportive, similar to some of the epi data for risk of colorectal cancer and other cancers in terms of physical activity and some diet. And I think the key for these patients is to have involvement in, a lot of the patients who have a genetic predisposition. There are clinics that follow them because there's various screening and things like that, and having that sort of integrated within the clinical care of those patients to discussions. So
I will get to my question in a second, but I'll just say that The AICR is advocating for legislation to require Medicare to cover medical nutrition therapy for people with chronic conditions, including cancer. And if you want to know more, you can email advocacy@aicr.org, and you can get involved in the advocacy work. And jumping from that, right? So if we can get insurance or government or whoever to cover all these things, question to everyone: how do you keep your patients motivated to continue on with these interventions? And maybe Dr. Schmidt, you can talk. You alluded to it a little bit.
How do we keep them going? Yeah, that $60 million question. So I think that there are within behavioral science, within our friends from the Society of Behavioral Medicine, techniques that are recommended for how we not only get people started, but how we make people continue. Certainly, I've been fascinated by the work of my colleague, Carrie Winter-Stone, at Oregon Health Sciences University. She was the one that cracked the code to try to get prostate cancer patients exercising by inviting their wives, their partners, to be a part of the exercise interventions. And she has had some really remarkable adherence in her trials. The other thing that we know, and this is a catch-22, because we know that doing supervised exercise and doing things in groups and supervised is associated with better adherence, because people will come because they're part of the group and they feel identification with the group and they really get a lot out of it. But that does not facilitate broad implementation and dissemination of our interventions, as exemplified by Dr. Demark-Wahnefried's Amplify PO1. And there is a movement happening towards getting more interventions to happen online, including my own work as well. So, if we're moving in that direction, we're moving away from what we know works to get people to exercise. And so I'm going to toss it to Wendy and see if she's got any clues as to how to get people to adhere with an online program.
Yeah, well, thank you, Katie, for the plug. And truly, if there's anybody out there, please visit the Amplify website. We'd love to get more patients. This is a nationwide trial, and anybody can join. We can do the trial anywhere in the continental United States. So please visit Amplify, Amplify My Health. Thank you, Katie. But the one thing that we do know is that we need to really kind of support cancer survivors, as well as people out there in the general world, to make lifestyle changes and keep with them for at least 6 months. Give them the instruction, then really try to pattern those lifestyle changes, support them, also answer their questions as questions come up. And it's really, you need that 6 month to almost a year period of time for people to make those changes. You can't really accomplish them with a one-shot diet instruction of 30 minutes and then expect that people it's going to change their life. Oh my goodness, this is an epiphany. Yes, it would be helpful, but it's not effective in being able to really create those long-term changes. So we do need programs that will support people over time. The behavior change world knows that there is a model that's kind of gotten out of vogue, called the trans-theoretical model, that you must be practicing a behavior for at least 6 months before it becomes ingrained, before you really identify it yourself as an exerciser, as a healthy eater. And it's only until we get people to that point that we can kind of release the reins and let them fly on their own, and let them fly toward better health. So we need those support programs.
So I would extend that too with, it's surprising the misperceptions that folks have about what is a healthy weight. You know, they're underestimating what they're eating, you know, their caloric intake, the types of foods they're eating, they're overestimating their physical activity. And so some reprogramming about what is truly a healthy lifestyle and healthy goals takes some time. Because just in, you know, we start early, read your labels. I say journal. Do you think you're not eating a lot? Journal everything you put in your mouth, you know, so you understand where, oh, I forgot about that brownie I did at the break time. You know, it's just amazing how folks can self-deceive about that.
Yeah, I'm actually really fascinated, Melissa, with the concept of maybe a one door in for behavior change is logging, and asking people to you know, we know food logging, you know, behaviorally, we know food logging does a lot. It just simply, you know, even if you don't tell people to change anything, they start to see, oh wow, I really did have potato chips every day last week. So they, you know, they start to see that differently, but also if they're starting to log their exercise and then noticing that they're not exercising. And, you know, and potentially, you know, one of the things that I like to talk to patients about is the potential for their exercise to become a way for them to know what's going on with their bodies, so that it's like driving your car on a regular basis. If your car makes a new rattle, you know that something's going on with your car. But if you don't drive your car at all, and it's making a rattle, is it new? You know, and so the patient that comes in to see Jeff, you know, who says, oh, I've got this new feeling, you know, who has been exercising regularly, it's like, yeah, no, I know this is different. That comes across differently in the clinical conversation than the person who comes in and has no idea what's going on with their body. And so, exercise then, and response to exercise can then become sort of a tool that allows the patient to help the physician with knowing what to do and what kind of care to provide.
And I'll just say, I think the future of this is also in wearable technology or sort of real-time readout. So both patients and their clinicians can sort of get an objective assessment of what they're actually eating or how much they're actually exercising, that sort of thing.
I would just like to interject. I really do like Katie's observation about the logging, because we know that that's kind of like at the top of the taxonomy of behavioral change. Melissa's too. People who just through the simple act of writing things down before they eat them will reduce their intake by 10%. We know this. Weight Watchers knows this. And so it is a really simple tool that we could employ for across time, and that bringing the simple act of recording and bringing it to the forefront may be even greater. There's some work by Rob Model, maybe even greater if we don't rely on the technology per se, because that doesn't bring it up to our monitoring. It doesn't bring it up to our head. It's just like a device I'm wearing on my sleeve, and we're not seeing the increase in physical activity from Fitbits and that sort of thing, maybe because of this, that we're not really conscious of those changes. I don't know, but it's a hypothesis out there.
All right, I'd just like to thank all of our panelists. I think we've had a tremendous discussion here. Thanks for the audience for the questions. I think everything was very good. I'd like to remind everyone that there is a poster session following this, so please do attend those posters. And with that, I'll wrap up the session. Thanks again.
Thanks, everyone.